Okay. Can you hear me? Well, hello, everyone. It's so great to see you all this afternoon. My name is Stacey Stewart. I'm President and CEO of the March of Dimes, and we're really pleased to have you all here this afternoon and maybe this morning, depending on where you are. This is our third viewing, our third episode of Healthy Moms, Strong Babies during the COVID-19 pandemic. And today I'm really honored that we have such an amazing group of panelists who are going to be here to talk about some of the impact that we're seeing as a result of the pandemic, especially the disproportionate impact on communities of color, and especially looking at what that may mean for even maternal and infant health outcomes as well. And I'm going to be introducing them in just a minute. I can't say how excited I am about all of them and how much they will have to contribute to this conversation today. Before we get started, I want to let you know we are on Facebook Live, and I know many of you are seeing us here. If something happens with the Facebook Live stream, we are also streaming this on YouTube, so we ask you to please go to the March of Dimes YouTube channel to check us out there if for some reason you're having problems with the Facebook Live. I also want to let you know that this allows us an opportunity to actually, on Facebook, see your live chats, your live comments, and ask the panelists to address those as well. So after we get through a little bit of the conversation, we'll be able to take some of your questions and some of your comments. Would love for you to chime in on this conversation. This is really a conversation that all of us can be involved in. So I want to say thank you all for joining, and it's a pleasure to be with you. Let me just kind of set the context, and I'll introduce our guests today. So we know that this COVID-19 pandemic is really creating a great amount of havoc in our society as a whole. But what a lot of us are seeing and a lot of us are concerned about are some of the disproportionate impacts that this is having on communities of color. Black and brown communities are more likely to die from COVID-19, and we're especially alarmed by the mortality rates that we're seeing in some of the cities that have reported out some of their data, like in New York and Chicago and Detroit and parts of Louisiana. We know, for example, in Chicago, African Americans make up more than half of the reported COVID-19 related deaths, but they don't represent half of the population. So we know that this is having a disproportionate impact. We're very concerned about it at the March of Dimes. We're also very concerned, obviously, about the impact it's having on moms and babies. Even before the pandemic hit, we were facing a tremendous crisis in maternal and infant health, and especially seeing tremendous disparities among Black and brown moms and babies. And frankly, very concerned about the impact that we were already seeing in those communities, but now we're even more concerned of how the pandemic may be affecting their health outcomes as well. We know that pregnancy is not something you can delay. We know that today, women that are pregnant are going to be delivering in the midst of the pandemic. We know that women of color are going to be delivering into a situation in which potentially their health is at greater risk and their babies are at greater risk as well. We have panelists and also can reflect on previous experiences with other viruses to see what kind of impact we saw during previous times and what we can expect to potentially happen this time around. So I'm looking forward to a great conversation, and I want to get into it now and introduce our guests. To support this conversation, we've got a range of different expert panelists. And I want to start by introducing our first panelist, Dr. Tori Como-Plowden, who is an OBGYN. She is the chief of the OBGYN department at Womack Army Medical Center. And so, Dr. Tori, thanks for joining. I'd also like to introduce Dr. Donald Warren, who is the Director and Associate Dean of Diversity, Equity, and Inclusion at the University of North Dakota School of Medicine and Health Sciences. And he's also a member of our National Board of Trustees at the March of Dimes. So thank you, Dr. Warren. Dr. Humaidi, who is the Dean of Howard University College of Medicine and also the Vice President of Clinical Affairs. Thank you for joining. And last but not least, our good friend at the March of Dimes, Tatiana Ali, who's an actor, an activist, and a member of the March of Dimes Advocate Celebrity Council. So thank you all for joining today. We're certainly pleased to kind of jump into this conversation. And I'd like to start with you. And if we could be on a first name basis, it would just make it easier for me. So I'd like to start with you, Tori. As an OBGYN, talk a little bit about what you're seeing in terms of pregnancy and delivery during this time, especially for women of color during the pandemic. Just set the stage for what you're seeing and what we're all seeing across the country.
So I think the first thing that we really must mention is that there are a lot of things about this virus that remain unknown. We don't have obviously any long-term research yet, and so we don't know overall what impact this is going to have ultimately. Um, Based on the limited data that we have thus far, it doesn't seem that pregnancy in and of itself increases the risk of people contracting the virus. Certainly women who have comorbidities, if they contract the virus, they may be at a higher risk of developing severe disease. But that seems to be true whether that woman is pregnant or not pregnant. We don't think, we're not 100% sure, but it doesn't appear that vertical transmission is an issue with this virus. What that means is that a pregnant woman contracts the virus, that she passes the infection through the placenta to the fetus. That does not seem to be the case. There was some research that was done in women in China who gave birth, and their infants were not impacted. But again, the data is very limited. We are not sure if there are any sequelae that would occur if a woman contracts this early in her pregnancy. We don't know if it leads to an increase in pregnancy loss or any kind of thing like that. We have not had any real data related to that. Regarding contracting this virus later in pregnancy, it's unclear with that too, as far as what the risk might be. There is some report that it might increase the risk of preterm delivery, potentially. But again, we can't confirm that at this point. COVID virus, so if a woman is pregnant and she is infected with COVID and she is delivering, it's time for delivery, COVID infection in and of itself is not an indication for C-section. So these women, if they were going into labor, they would be allowed to go into labor and potentially deliver vaginally, as long as they weren't having any other issues. But COVID in and of itself is not an indication for C-section. Something that seems to be concerning, difficult for pregnant women right now, is the lack of having a large group with them during delivery. Many facilities have restricted who can come to the delivery ward because, you know, our patients are, it's a special environment where we have neonates, brand new babies. And so we've had to limit who can come to the ward. So many places across the country are limiting that to one support person. And I know that that can feel very uncomfortable for some patients, but we are trying to do it to keep everyone as safe as possible.
Yeah, that is a concern, and we've heard that a lot. And we actually talked a little bit about that in some previous webinars too. And we know that actually there have been some states that instituted those kinds of policies to limit the number of birth partners to no one in the delivery room, and have had to reverse that. But I'd like to actually turn to Dr. Mighty, if you don't mind. We was planning to go in a different direction, but Tori, you just said something that made me think about this. And Hugh, if you could just touch on this really, because, you know, you're at Howard University. Howard University, for a lot of folks, I think a lot of folks know, right in the middle of DC. Howard University Hospital, associated with a historically Black college and university, Howard University. You're dealing with a predominantly African-American population. Tell us what you're seeing right now, especially in the hospital, in labor delivery, and what are your concerns right now with respect to women of color who are trying to deliver at this point in time, and what are your concerns about the impact disproportionately on them? And I think Dr. Hugh, you're on mute.
There we go. I've got it. So yes, I agree with Dr. Plowden in that we don't seem to have any data to say that pregnancy in and of itself promotes a higher risk. But what we do know is that, especially taking Washington, D.C. and many places in the country where minorities, women of color, have a higher incidence of risk in their pregnancies, period. So they have higher preterm birth, where there's a higher maternal mortality, higher infant mortality. And where I think the largest stressor has occurred for us is that many of our constituents, our patients, are being hit by the social aspects of this thing. It's when you put people on social distancing and you lock them down, they can't get to prenatal care, which is one of the key things that we have for addressing these women at higher risk. So that's a real problem, just getting to prenatal care is an issue for them. Social distancing in and of itself can be an issue for them because many of these women live in communities where they're close together. It's not the same as if, you can just say, let's go separate. And the third thing, especially we're seeing in Washington, D.C., where we have a limited public transportation currently, getting to a doctor is for them an access point. It's not an insurance issue. It is a problem that they simply cannot get to it. So my biggest concern for the population is that we have implemented, and rightfully so, we've implemented a policy that in a sense disadvantages even more those women who are already at the higher risk.
And I guess the real question is if COVID-19 is really disproportionately impacting communities of color, at least based on some of the information that we're beginning to see, and again, it's very early on, are you concerned about a disproportionate impact on the moms of color? And it may be because of all these reasons, the social reasons and things like that, but is it natural to assume then that if we already had a health crisis with Black moms and brown moms and babies, that could even worsen as a result of the pandemic? Hugh?
Certainly, that's going to be a concern. One of the things we do know is pregnancy is not protective for what we do, for many data that we have currently. What we have seen, at least is in the data, is that although we anticipate there's going to be certainly more infections coming out of New Jersey, New York, there are moms who've been infected who seem to be able to weather this at a, let's say the morbidity rate is much lower for these moms. So we're hopeful that while they may become infected, that we're not going to see the same spikes and peaks that we're seeing in the rest of the population. But we certainly anticipate that, yes, the infection rate is going to be certainly the same across the board. We just don't have enough data yet across the country even to start to say, what are we seeing in this population? I certainly think back to other viruses that, like H1N1, which was the flu virus back, where I thought pregnant women were certainly being impacted severely and more acutely than much of the population. Right now, we just don't have the data, but we certainly have to keep an eye on it and watch for those signs.
Thanks, Hugh. And Dr. Warren, Don, you are in North Dakota, and you've a lot of experience personally and professionally in working on in the Native American communities and Hispanic communities as well. Talk a little bit about what we're seeing in those communities as well. There's been a lot of talk about African American impact, but I think we must focus on all communities of color. So give us a little bit of understanding of what's happening among Native American women and babies and communities, as well as Hispanic.
I think it's important to acknowledge that we have American Indian people who live on reservations, as also those who live in cities as well. So we see kind of a mixed bag here. So in some of our tribal communities that are on reservations, we're seeing outbreaks and hotspots, unfortunately, of COVID-19. In Arizona, the Navajo Nation has been hit pretty hard by the coronavirus. Here in the Dakotas, we have several tribes that are now testing more and more positive cases. So one of our big challenges, of course, is that we have to collect the data within Indian Health Service and tribal health programs on the reservations. But actually, the majority of American Indians live in cities. And I think some of the challenges related to adequate racial and ethnic data collection in the cities is also probably underreporting the problem for indigenous people who live in cities. So it's not just an issue on the reservations, it's also an issue within the urban American Indian population.
And of course, there are a lot of issues with underlying health challenges in Native American and Hispanic populations, similar to the African American community. So what are you seeing in terms of the way underlying health conditions are probably exacerbating some of the impact that the pandemic is having in those communities?
We know that people who have diabetes are at greater risk, and unfortunately for American Indians nationally, we have the highest rate of type 2 diabetes and typically poorly controlled diabetes. In addition to that, particularly in the Northern Plains where I am located, we have very high rates of cigarette smoking. So use of commercial tobacco and higher rates of asthma and chronic obstructive pulmonary disease, other chronic conditions, including diabetes, put our people at tremendous risk. And in addition to that, we have other social determinants like overcrowded housing and poverty and underdeveloped public health infrastructure that all kind of combine together to put our populations at tremendous risk for COVID-19, including, of course, pregnant moms and babies.
And I hope everyone can hear me. I'm a little stuck on the screen, but I'll keep going. Tatiana, I'd like to turn it to you. What are you seeing in terms, I know you've had a lot of concern about implicit bias in the healthcare system, especially as it relates to African-American women. As an African-American woman yourself, talk about what some of your concerns are about the impact that it's having, the pandemic is on communities of color, and are you particularly concerned about what impact the pandemic may be having on moms of color and babies of color right now?
I am concerned. I began to learn about reproductive justice and the maternal health crisis, mortality crisis with Black women after the birth of my own son, and our experience at the hospital, which, took us a great deal of time to actually work through and to get over. I had a really healthy pregnancy, and it my primary care physician was not there at my birth. And so that was really my introduction to the maternal health care system, the structures of it. And that was also my first experience with just not being listened to, unnecessary interventions happening, which led to an emergency C-section and my son having to be in the NICU. So that's where I started to get involved with this and realized that, my story was extremely similar to, the stories of women all over the country, women of color specifically. And as everybody's saying, this pandemic is exacerbating all of the inequalities that we already know exist. And my hope is that, the pain of people of color don't fall on deaf ears again. I'm also concerned. I have friends who are pregnant right now who are, waiting for their babies to come. And I'm concerned about the social distancing also leading to isolation. It's not just, what happens during birth or before, but also a lot of what's affecting Black women and women of color happens in the postpartum period. So, where's that care coming from? How are they going to get the support that they need then? I'm isolated in my own house. I'm not a doctor, so I'm not privy to these studies, but getting the information out and is really a concern of mine, and making sure that Black women are heard and brown women are heard.
Right. And I think one of the things that I know we've seen at the March of Dimes, and I think we're really concerned about, is we're not even sure that all the data that we need to be collecting on what's really going on is actually being collected right now. And I don't know if you're seeing that in your particular areas, but it doesn't appear as though we're even collecting the right kinds of data to even know and understand what we're even experiencing now, much less understand it, when we get through this and then can reflect and say, what could we have done better? And, Hugh or Don or any one of you all, do you agree with that? And what is it that we can do now to sort of be advocating for these communities of color to say, what is it that we know today that we can start even responding to today? What data should we be collecting? What should we be learning right now about the pandemic, especially the impact it's having on communities of color and on maternal and infant health?
Right. Well, so one of the first things we really need to keep trying to do is to get the information as to who and how many people are really affected. Without that information, it's really hard to practice or to give advice as to where and how. We can say social distancing, but it's even more effective if we know, for example, through testing who is or is not positive. It may help guide us, for example, in a simple way. We are stopping birth partners from entering a hospital with their partners. If we had that information and sort of had some grasp on that, then at least it may inform our decisions. Right now, we treat everyone as if they're positive without really knowing. So I think it's helpful if we can get more data. And the second thing is, it's hard to tell what really is the impact, who is getting infected, and those kinds of things, if we don't have information to surround through testing. So it really is still, I think, imperative that we raise the bar on testing and keep trying to get more numbers in.
And to the extent that, oh, go ahead, Don. Sure, please.
Yeah, I'd just add that obviously we need more testing, and in many of our communities that are impoverished and underserved, we do have less testing. And in some of our reservation communities, there's just very little testing going on. And the next step in terms of data collection is contact tracing. Once you have a positive case, you need to know who they were in contact with. And in some of our communities with overcrowded housing or congregate housing, group homes, these types of things, many of our people are at tremendous risk. So I'd say the most important data, I would agree with Dr. Mighty, we really do need more testing. And then in addition to that, better collection of racial and ethnic data to get a real understanding of the disparities.
So we actually do have a question coming from Facebook Live, and it has to do a little bit with testing and symptoms. What the question is, we have there's been a report saying that there's a high percentage of pregnant women who test positive for COVID-19 and are asymptomatic. And so what are the risks associated with this? And so Tori, Hugh, Don,
I guess, so there is talk among, so this was the data that was put out into the community yesterday or the day before. And it basically looked at a study, I think out of Columbia, it was definitely in New York. And I think over this time period, they tested approximately 200 women. Of the women who did test positive, approximately 80 or 85% of those women had been symptomatic. This just highlights the fact that what the other panelists were just saying is that we do need to have more testing. What would be perhaps more ideal would be that if in labor and delivery at admission, people could be tested, that might help us to better understand what's going on with them. Again, pregnancy in and of itself does not seem to necessarily play a role in if the person will have mild, moderate, or severe disease. But certainly if the person is positive, we would be treating them differently. There would be additional isolation precautions to decrease the exposure to the other staff, and then and et cetera. So testing is really important. The fact that people are asymptomatic, that's okay as far as for their own condition, but it doesn't mean that those people are not infectious. And certainly we would not, a person who is positive and is potentially infectious, it has implications with her being around her own newborn as well.
And Hugh, I think you were saying that right now in the hospital, a lot of people are just assumed to be having contracted the virus already, even if they may not have been tested and have been proven to be positive. But tell us more about that. How is that actually working, especially in labor and delivery? If a woman just shows up, is she assumed to be potentially having already contracted COVID-19, and are then the right kinds of protocols put in place in terms of how to interact with her, with health workers and others?
Right. So I think we have a sort of a global approach to this. It's not singling out that mom. It is, I can't tell if you're still speaking.
No, I can hear you.
Okay, thank you very much. So we're not trying to single out that mom. There are two things to think about here. One is the other population that's disproportionately being affected are healthcare workers. And they get exposed, and then they are at risk for exposing others. And so we have to take an approach in light that there's not enough testing. We have to make the most conservative assumption, which is anyone, whether it be a healthcare worker or a patient, could be infected and not have symptoms and then be at risk of transmitting that, not just to the patient, but vice versa. So we do have a standard sort of policy around, assuming that everyone might be positive. Right now in our own hospital, we're trying to adhere to a mask policy, even though masks are precious and they're trying to protect both the healthcare worker and the patient as well. So in that sense, we view everyone as potentially being positive. And then if they are symptomatic, then we raise the bar in terms of how we approach the other things around them.
And I think we may be having a little video lag, but hopefully you all can still hear the audio, and that audio is moving. So we'll just keep moving so that you all can hear it. I think one of the other things that is to the extent that people are uninsured and, for example, they're pregnant now. What are the potential challenges that we're seeing with respect to now addressing that on top of, or with the pandemic now on top of all of that? And I'll throw it open to anyone.
Because of the lag a little bit, I will be happy to take the question. I didn't hear the very first part of the question. I heard insurance as being the only piece. So if you say that again, I will be happy to give you my 2 cents.
Just that we have a lack of insurance among a lot of within many communities, people of color and across communities of color. And so how is the lack of access to insurance also then impacting people's ability to get care, especially now in light of the pandemic?
Yeah, so it's, I would say that in most states, people of color still have access to insurance across the board. I think that insurance, so you take the District of Columbia, we have roughly, when you look at Medicaid and so forth, 96% of our population are insured. That insurance, however, does not alleviate the access issue of them getting to care. There are areas, and this is true in rural areas across the country, where there are no hospitals for them to deliver, their babies and are very far away to go and get that. So if you compound that now with this pandemic, it makes it more difficult for them to get into care, regardless of their insurance status, which of course places them at a higher risk for poor outcomes.
Okay, great. We have another question too, that there are people who are very concerned. Hopefully the audio is still working, so sorry about this video delay. But we have some people, there's another question that people are very concerned that loved ones are giving birth really soon. And I think for people of color who are giving birth now soon, especially, are there particular concerns? Are there particular safeguards that we can give and let women know that they can pursue if they are about to give birth in the next few days or weeks?
There's some thought that perhaps at 37 weeks, or when a person's due date, they're about 40 weeks pregnant whenever they have a due date. There's some thought that perhaps around the 37-week time frame that mothers kind of go into a more of a substantial social distancing pattern, where they kind of are keeping themselves away from people to decrease the likelihood that they might have COVID at the time of delivery. That's one thought. I'm not saying that that's something that everyone is doing, but it's one thought that could potentially decrease exposures as the woman goes nearer to term and would be about to go into labor.
I have a question.
Yes.
Tagging onto the question that was asked, what about, is there any thought about, it was mentioned previously, but potentially mothers passing COVID on, people who are asymptomatic, who don't know because there aren't, enough tests, or I don't know if all pregnant women in all hospitals are being tested, possibly passing that on, and how breast milk is affected, if breastfeeding is, deemed helpful. I know breastfeeding, breast milk has antibodies. If you are carrying it, is it more recommended now? Is there any thought about that at all?
So there are two things there. One is I certainly would not stop folks from breastfeeding if they're from their infant. I would treat breastfeeding as I would treat hand washing. I would think through the idea that you really ought to think about as you'd wash your hands, you'd clean any other area, because we're talking about contact. There are certain immune benefits that are given to babies through breastfeeding. So I certainly would not decrease the advice around breastfeeding. There's not any direct evidence at this time that COVID is going to be transmitted through breast milk any more than it's going to be transmitted through any other foods. So what we think about is whether or not there could be contact, and most of that contact may come from hands. If you think about hands trying to get babies to attach for breastfeeding, then again, you want to have as clean an environment as you can for that infant. But I would not tell moms not to breastfeed. I think that we don't have any data that breast milk in and of itself is going to lead to a higher incidence. And I think your other question was around are people asymptomatic? We have to assume, 50% of the people may be asymptomatic at any given time. So I think the greatest part of precaution is to make the assumption that you may be infected and that you could transmit, and then to practice not just distancing, but as I said, we can use masks and other things to make sure that we can be as safe as possible. I don't think that we can ever say we can get you to a 0% risk.
And I think if you all can still hear me on
Hi, everybody. Stacy lost video and audio, so I'm just here to fill in for just a second. So we can just keep going. I'll just ask another question that we had from Facebook, which was about a CDC case report, right? And is there on any of the CDC specific forms that you've seen, is there a specific question related to moms or babies or dads?
I can't think of a specific form, but I know the CDC is absolutely tracking outcomes for pregnancy, for infants, to look for that vertical transmission or close contact transmission. So in the data sets that we fill out for most people who are tested, in that data set, there is information, questions about actual pregnancy and or the ages and so forth. So that data, and the CDC does try to write up in their weekly report any new information that they have relative to any particular population at risk, and pregnancy being one of those.
Great. Thanks, Dr. Mighty. I wanted to ask you, Tatiana, specifically to maybe talk about your experience in the hospital being a minority, and if you felt like there were any impacts to your labor and your delivery and your care around that. And then the doctors, if you could chime in on how that might be affecting minorities during this time.
Well, I have two boys, a 3-year-old and a 8-month-old. And so I had very different experiences with both. I think we learned a lot from our first experience. We were naive about, the kind of birth that we could have in a hospital setting. And we kind of rectified that the second time around. We had like a paradigm shift at home. But like I said, my primary care physician that patient-centered care wasn't available to me because my OBGYN wasn't there. And I felt that I know I wasn't listened to. I was, yelled at. I could see my son's head, and, by the end of it, there was a doctor a doctor who was, physically, he stuck his forearm into the top of my belly really forcefully. Towards the end of it, my son was pushed back inside me, and I was rolled into in for an emergency C-section. And from the trauma of his birth, he didn't urinate right away for a couple of days. He had to be, they had to use a catheter on him a few times, and he was brought to the NICU. We had our birth plan, and it, no one followed that. And we tell people to advocate for themselves, but it's difficult when that's your first experience. and you're in, the throes of labor. And what I learned from that, also kind of like the PTSD that our family had to go through after that experience, and kind of, I'm lucky that I have a husband who really is communicative. He likes to talk. And so we talked for about a good year and a half, trying to suss through what we experienced. And when I became pregnant with my second son, Alejandro, I decided to look for another way, and ended up attending a lot of birth summits, found out a lot about midwifery, found out a lot about reproductive justice, and that my story was very common. And luckily we came out healthy and okay after it, but it didn't necessarily have to be that way.
Yeah, that sounds pretty difficult. Glad to hear that, you guys have come out on the other side of that and you're able to speak about it now.
It was, the hospital that I was in Los Angeles was very different. I ended up being in a hospital for my second son, UCSF, but it was a completely different experience because they were creating change within their hospital and are continuing to do so around patient-centered care, around culturally competent care. There were many doctors of color, women of color specifically, caring for us there. My midwife was allowed to be there. We were, our choices were respected. We were heard. And it was a completely different experience. And, yeah, the cultural competency part, people being listened to and people being heard when they come in, or when they say they have pain, I think that made a huge difference for us.
Great, thank you. Doctors, do any of you have anything to say about possible racial profiling against minorities in the hospitals now during the COVID time? Can anyone hear me?
Can you repeat your question?
Sure. I just wanted to know if you had any thoughts about pregnant women going into the hospitals now, in our minority communities, and how racial profiling might impact their process.
So I think a couple of things that I heard Tatiana say, were eyebrow raising to me. And it's certainly not the first time that I've heard these sorts of sentiments. It does appear that Black women do feel that they are often not heard. There have certainly been studies in the past that have indicated that specifically related to pain, and not specifically pain in pregnancy, but pain, that Black people have not always been treated. They have been thought to be drug seekers. They have not always been treated. Their pain has not always been treated or hasn't always been respected or listened to. It seems like there's more doubt there. And I have had pregnant patients say that they have felt in OB visits or in the labor and delivery room that they have not been listened to, that they don't feel like their thoughts have been respected. And this is an issue, I think, that is prevalent at any time. With COVID, I'm more concerned that because it's a different situation, because it's a more higher stress situation for people in the hospital as well as healthcare workers, that perhaps the idea of listening to patients might not happen, or may happen less than than it already does. The other thing that you said to me was that caught my attention was that your experience was much different because you had a more diverse population. We do know that representation matters. As a Black woman myself, I have had patients say to me, I feel like you listened. I don't know if that's true or not. Not to say that other people don't listen, but they at least felt that they could identify perhaps with someone who looked like them. And so representation, it does matter. I think taking the time out to sit at eye level with your patient and try to listen to what they're saying makes a difference in your patient's perception, and it also makes a difference in your own perception. I recently read a study, it was done several years ago, but it was basically talking about how they timed how long doctors were in the room with the patient. And when the doctor stood up, the patient perceived that they had been speaking with the doctor for less time than when the doctor sat down. But in that study, they timed the amount of time that the doctor was in the room, and the doctor actually was in the room a shorter period of time when they sat versus when they were standing. Now that's just one study, but it gives me to build relationships and to feel heard and understood. It has to be, people have to feel not as rushed. People have to feel like that the doctor is listening to them, not interrupting them, and that they are able to speak to what their concerns are and to have those concerns addressed.
Can I add something that I think is important about, when we talk about communities of color and what's happening to them health-wise, that there's, as I've spoken to women about this, I've had women also tell me, people who are beginning to start their families, I'm so scared to start my family because I know we're dying while we give birth. And there's oftentimes the story gets told in a way that makes you think that, we are biologically predisposed to die giving birth, or in this case, to contract and die from, COVID-19. And I just want to make sure that the story is told fully, that it's not, we're not getting it and suffering from this at higher rates because we're Black and brown. It's because of the structural inequality that we're, I guess, living under, working with, or whatever. But that it's not because we're Black or brown. I feel like that way of telling it, our stories, our health stories especially, gets, it gets confused.
Absolutely. Dr. Warren?
Yeah, I think that's a valid point.
Oh, keep going, Dr. Mighty.
Go ahead, Katrina. No, I just think it's a very valid point that what happens is many times we take a small story and we propagate it, just as you're seeing now as some of the questions come up, should I get pregnant in this time, and is it going to be? And the first thing I would say is COVID is going to be with us a very long time. I think you cross over when we get to a vaccine that we can actually do something about it. Because even if you look at some of the methodologies that are being tried now relative to pregnancy, not all of them are going to be safe to be used in pregnancy. So that's going to be a challenge for us in terms of treating the disorder. But in terms of, advising patients, I would say that the risks are going to be there for a very long time to come. Number one, and what we have to do is recognize that the general population of women, especially women of color who are going to get pregnant, are going to have these higher risks embedded in their course anyway. And so I go back to, I don't believe necessarily that at this point the data is not showing that the virus itself is causing that to rise much more at this point. So I would go back to saying getting pregnant is a matter of, at this point, I would delay deliveries if you could for a while until we get a handle on the number of patients in hospitals. That's where we're going to see the biggest impact, is the number of patients within a hospital currently, when lots of states are just peaking, are going to certainly impact a lot of resources that you have or don't have. So, if you're coming in to deliver now, as you see, we're separating women from their birth partners. We're taking, extraordinary measures to protect everyone. So this may not be feeling like the best environment to be in, but long term, I wouldn't again say to someone you shouldn't become pregnant. The other thing I wanted to say that I think is so valid that you talk about is women in labor are very vulnerable. I mean, it's a time of pain. You're not making necessarily what I'd call the rational decisions, and so many comedies have been written around that, but it is true. You're very vulnerable. And as healthcare workers, what we have to be mindful of is not just our own biases, but in our heads to be able to say, I am going to partner with this person and be an advocate rather than be a parent. And it's easier to be a parent because it makes what I perceive, which is your pain, to go away if I can just tell you what to do, rather than trying to work through that. And even among women of color, different ethnic groups handle labor and delivery very differently. And so we try to apply the one size fits all, and that's not going to work. And so I'm very sensitive to the fact that it's cultural competence has to go even within minorities, right? So you would say, well, if you're a person of color, how people deal with this are very different. It is heightened now because there is fear. There is fear among the healthcare workers. So I know the longer time I spend in contact with you, especially if you are known positive, I begin to feel the pressure of, am I exposing myself? Am I putting myself at risk in order to care for you? So it really requires us to dig deep and remember we have a purpose that we serve, which is to help deliver healthy babies and to take care of mothers more as partners than the fears that drive ourselves as caregivers.
Great, thanks.
The only other thing that I would add to that is, I think you're right, Tatiana. You do bring up a good point. It's not as if it's Black or brown people's fault that they may be contracting these illnesses. Health does not exist in a vacuum. And there are a variety of things surrounding that. So for instance, many people in those communities may not have the option that they have a job where they can telework. A lot of these people have to go into, they might be essential employees. They might be the people who are working in the grocery stores. They might be people who are working in factories or wherever it is that they work. It might not be possible for them to social distance and be at home and have telework and still be getting paid. So that's also something that you must consider when you're thinking about this. Or some of those people may not have jobs that have sick leave. And so if they don't go to work and they don't get paid and then they can't feed their family, that is the biggest threat to them at that time. I think I've seen it portrayed a little bit in the media as if Black people or brown people are not taking this disease as seriously, or that they are just, saying, oh, it's not a big deal, I'm going to go about my normal life. And I don't think that that is actually happening. And I think that that is a dangerous idea to perpetuate, that these people just don't care or people are just not taking things seriously.
Thank you. Can any of you talk about issues of trust that might be happening in hospitals now with pregnant women, and then after that, we'll maybe move into talking about how we can come up with some policy changes. Dr. Warren, can you speak to that, issues of trust?
Sure, and particularly for American Indian populations, we have a very, very unique health system with the Indian Health Service, and it's been a strained relationship over years. And one of the outcomes of that is a lack of trust quite often among community members toward the health system or toward the government. So one of the potential negative outcomes, particularly with COVID-19, is that when we get federal recommendations for prevention and for isolation, sometimes those messages are not trusted because there's a lack of trust with the health system in general. And for American Indians who live on reservations, particularly in the Northern Plains, we do have local hospitals and clinics, but most of them do not do deliveries. So our patients then have to travel quite a distance in some cases to do the delivery, and they may or may not know that provider on the other end. So I think there's a whole host of issues that have been a part of American Indian healthcare and other populations as well that I think gets highlighted during a time like this where there's a pandemic and there's even greater concern about poor outcomes. But I think a long history of ongoing mistrust among community members toward the health system and vice versa in some cases leads to more risk, unfortunately.
Yeah, thank you. Do any of you have any recommendations for policies that'll help with equity in our healthcare system?
So I think that, you know, there are lots of things that we need to do to make it easier. And I'm talking about equity, particularly towards pregnancies. I think we need a broader infrastructure. We tend to place prenatal visits with physicians at the center, being a thing. And even in our midwifery structure, we still tend to collect things within one center, which we're seeing, as opposed to distribute them towards, especially in our communities around access, it's taking that access to the patient. I still think that we could do a lot more of taking access to the patients, because not every person is a high risk patient, but they develop risk along the way, and being able to identify those early. And as you talk about building trust, trust comes a lot, not just from, you know, you like to have your OBGYN and have that one person, but what we've learned a lot from looking at midwifery and the centering programs around obstetrical care, they've been very effective in identifying risk very early and in addressing those risks among that community of women. I think we need to address more and more the concept that pregnancy and communities go hand in hand. And although the healthcare system is a part of it, I don't think it should be the primary part. And many times if I give lectures to folks and I'm speaking, I start out with a simple statement: pregnancy is not a disease by any means. And so we have to recognize that and adapt to the fact that pregnant women do get diseases, but it's not a disease. And how we deal with that socially and through access points, moving access points away from hospital and centralization, I think is a policy that I think may bear fruit in the future.
Yeah, and I would add to that, just thinking about policy opportunities right now, not every state has expanded Medicaid. And for example, in South Dakota, we have kind of a terrible combination of no stay-in-place order with no Medicaid expansion, high rates of poverty, particularly for American Indian women and children and families. We have less access to services. So I keep hearing a lot of people say, when are we going to get back to normal? And from my perspective, I hope we don't get back to normal. I hope we get back to better. You know, we have policy improvements that we need to focus on access to public health services as well. It's not just the medical care. We need more investment in public health and infrastructure. And I'm hoping that this particular pandemic will unveil some of those real areas of need. And I'm hoping through policy solutions, we can increase access to those services.
And so COVID seems like, you know, we've had to change the way that we think about care substantially, because we're now trying to figure out how to deliver care in this setting where we're socially distancing. And so telemedicine, or the opportunity for telehealth, has certainly been something that we've seen a major increase in that in the last several weeks. I've had some patients who really enjoy the telemedicine kind of model. And I worry, or, you know, I wonder that, you know, communities of color may not have access to that same technology. So I think we need to make sure that we kind of develop that. Telemedicine actually has the possibility to really expand care, particularly in rural areas where there are not that many OBGYNs that are in that community. It may be that many of the visits can be conducted via telemedicine, and perhaps that if insurances are covering, for instance, a home blood pressure cuff for a patient, she could be able to take her blood pressure, let her doctor know what's going on, and if that patient needed to come in to be seen, then that could be arranged. But this may actually expand access in thus far unexplored ways, and so it may be the future.
Great, thank you. We really appreciate everyone participating today. I know Lucy apologized for the technical challenges she was experiencing. But we really do think this was a great conversation. Our topic next week, and we hope everyone can join us then, is bringing your baby home during the pandemic, and all the different things that you might need to prepare for to make that happen successfully. So if you're so inclined to give to March of Dimes during this time as we bring forth all of this information to all of our moms and moms to be, feel free to text Mod Give to 51555. We really appreciate any donation that you are so inclined to make at this time. Tatiana, thank you so much for your personal perspective and for sharing your story with us. And Dr. Plowden, thank you. Dr. Mighty, thank you. And Dr. Warren, thank you very much. And Stacy, if you can see and hear us, we thank you too.
I don't know if anyone can hear me, but I can certainly hear you guys, and you guys were awesome. And thank you so much. And I apologize for these technical difficulties, but I'm so glad. I think we had a fantastic conversation. Thank you for all the panelists and everyone that joined.
All right, we will see you all next week.
Thank you, guys.